All right, we're going to go ahead and get started there now. Miigwech merci beaucoup, and thank you for joining us for our Lunchtime Health Sciences webinar today, Life is Sweet, Understanding Lifestyle Factors in Diabetes Management. My name is Bethany Thompson, and I'm the Health Sciences Programs and Partnerships Coordinator here at Awesome University. And today's webinar is being delivered by Caitlin McLeod. Before we get started, I will do a land acknowledgement and formally introduce Caitlin to the folks on the call today. In the spirit of truth and reconciliation, Nawsum University respectfully acknowledges that our pan-northern campus is on the homelands of First Nations and Métis people. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wanapitei First Nations and Fort William First Nation. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teachings with us so that we may better understand and honor their wisdom and that of all the traditional keepers of this land. Nawsum University will continue to practice reconciliation by listening, learning, and fostering a cultural mutual respect and trust. This is a friendly reminder to please keep your microphone off for the duration of this webinar unless you are asking a question or responding to a question posed by the speaker. This will help to limit background noise for everybody. This webinar is being recorded and will be posted on the Rehabilitation Sciences and Dietetic Practicum Program web pages. All of our previous health sciences webinars are on the Nawsum YouTube channel and can be found on our Rehabilitation Sciences and Dietetic Practicum Program web pages in the resources sections. You can view these archive webinars at any time and receive a certificate for your professional development records when you complete an evaluation. If you do have any questions about the presentation, please feel free to put your questions in the chat, and we will have a Q&A period at the end of today's webinar where our speaker will answer any questions that you may have. I'd like to welcome our speaker today, Caitlin McLeod. I graduated the Nawsum U Dietetic Practicum Program in 2019. Caitlin has been practicing as a registered dietitian in Northern Ontario for the last 5 years. She pursued her undergraduate degree at St. Francis Xavier University with a Bachelor's of Science in Human Nutrition. Her career has given her experience in both inpatient and outpatient settings, inclusive to specialization in nephrology, diabetes, pediatrics, and more recently in the last year as a member of the City of the Lakes Family Health Team, servicing the Greater Sudbury area. She was a member of the HSN Diabetes Education Program with a leadership role in the Gestational Diabetes Program and eventual transition to the specialization in pediatric diabetes care. Throughout this journey, Caitlin found her passion in diabetes care and pursued further certification as a certified diabetes educator. Now, Caitlin practices in a setting where she assists patients of all ages of all nutrition-related concerns, but maintains a specialization in chronic disease management. She's the designated diabetes program lead with the City of Lakes Family Health Team and passionately leads diabetes education classes, diabetes awareness month initiatives, and ongoing patient care for those living with diabetes. Caitlin practices in a health at every size approach with a strong passion in knowledge sharing and empowerment of patients. She utilizes a patient-centered care model to assist patients in making small but effective lifestyle changes that can benefit their overall health and well-being. Caitlin, thank you so much for being here today for the webinar, and I'm going to pass it over to you to share your screen and start today's webinar.
Wonderful. Thank you, Bethany. Bear with me while I share the screen to share the PowerPoint, and then we can get started. Can I confirm that we can see the presentation?
It looks great, Caitlin. Thank you.
Wonderful, thank you. I do actually have you on a second computer, so I can still see people throughout this presentation while I also have the laptop up. But thank you, Bethany, for the wonderful introduction. As mentioned, my name is Caitlin McLeod. I am a registered dietitian and certified diabetes educator, currently working for the City of Lakes Family Health Team servicing the Greater Sudbury area. Wonderful to see the turnout, quite a few familiar names. Very excited to have those familiar names and some unfamiliar to me join today. The presentation today is titled Life is Sweet, Understanding Lifestyle Factors in Diabetes Management. This presentation is very unique in the sense that I'm presenting to other healthcare providers. I was advised there's a fair amount of dietitians here, which is wonderful. But the goal is to introduce some ideas of diabetes management if you have a patient in any practice setting that you are in any capacity that you have as a healthcare provider. If diabetes comes up as part of your conversations, what are some tangible things we can provide to those patients, suggest to those patients, and where can we direct them to learn more? I do have some disclosures to begin this presentation. So this topic of interest was put out as a call. I expressed interest, and NOSMU has graciously invited me to join them for the presentation today, and I am receiving an honorarium as a result. I do want to disclose that, as Bethany shared, I do have prior experience specializing in diabetes centers and with my current role at the City of Lakes Family Health Team. However, this information is not representative of any of those organizations directly. It is all generic diabetes information that is all rooted in our governing agencies such as Diabetes Canada, Canadian Practice Guidelines, etc. I also would like to disclose that I currently am not living with diabetes, and I think that's an important marker to share. I have a wealth of experience in working with many individuals living with diabetes at many different courses of their life, but I do want to disclose that for myself personally, I do not have any lived experience. Getting started today with our learning objectives, I am hoping to develop an appreciation of the impact of living with chronic conditions that they can have on our patients and ways as we as healthcare providers can help them with that. All of us that are involved in healthcare have some degree of knowledge in respects to this, but I think it's important that we really acknowledge some of the heavy burden, especially with diabetes, and little things that we can do to make that acceptance of a chronic condition more beneficial for patients, help make it easier. I want to enhance the participants' understanding of all the factors that influence diabetes management. Spoiler alert, it's not just food and medications. There is a lot that goes into it, and I think having that appreciation can be very beneficial no matter what setting of practice you work in. And I do want to differentiate between some of the interventions for those living with type 1 diabetes versus type 2 diabetes versus gestational diabetes. The interventions are variable and different depending on what specific condition we're targeting. And I like to have those types of conversations. There is time, as Bethany identified, for questions at the end. I do ask that you hold on to your questions. Please write them down as we go, and I will certainly circle back to that opportunity. If we do not have time, I am more than happy to share contact information and correspond via email, phone call, or any other way you wish to communicate. Beginning speaking to life with a chronic condition. So chronic condition is not just diabetes, as we're all well aware. Chronic conditions can be cardiovascular, it can be a wide variety of situations, but we know that living with a chronic condition impacts both our physical and psychological well-being. Being diagnosed and living with a chronic condition is very scary. It's very frightening for our patients. And I have spent a lot of time, although my role as a dietitian is just a nutrition focus, a lot of that supportive listening and very patient-centered care to give them that space to share their concerns and share their fears about this chronic condition can really empower you to understand where are the knowledge gaps. How can we help assist in understanding our chronic condition? And that can help lead to that empowerment, which, as Bethany shared, I'm very passionate about. Our evidence suggests that understanding and receiving that information about the condition is also helpful for coping with a new diagnosis of a chronic condition. We've likely, any of us working directly in patient care, have come across that patient where we recommend you do A, B, and C. They come back and see you 3 months later and they haven't done A, B, or C. And it's a little bit frustrating at times as providers, but that is an opportunity to stop and think, well, why not? What are our barriers? Sometimes patients are just not accepting of their chronic condition at this time. And what can we as the healthcare providers do to help with that conversation? Often sharing our knowledge of that chronic condition, what are the risks, what are the interventions that we can consider as options, can help them to cope with that diagnosis and begin to implement changes. We also know that connection to support and communities are very assistive in management strategies. So when we have the ability to work in a setting where we have allied health professionals at our disposal, whether it's, if we're thinking physicians, if you have the ability to connect with your allied health, such as dietitians, social workers, pharmacists, all of our roles can create a supportive community for these patients and help them to feel like they're not alone in this. As well, connecting with other members that are living with a chronic condition, we also have strong evidence to share that it very much helps their management. Things like education classes, where you have multiple people attending for understanding the same condition, even just seeing a room full of other people that are there to learn about the same thing, really has an impact and can really help them feel motivated that they're not alone. I have a balloon on the screen here. I have done this activity in many presentations in regarding diabetes. Given that we are virtual today, I was not able to participate in it. However, quite often what I like to do is have a balloon blown up, and while we are speaking throughout our conversation today, I would have you bouncing the balloon in your hand. This is a very strong demonstration of what life is like with a chronic condition. Specifically, it's very reflective of life with diabetes. Blood sugars are consistently moving no matter what we are doing throughout our day. Having a balloon bouncing in my hand right now while I'm trying to speak with others, while I am trying to, keep my thoughts straight and enjoy this experience, my blood sugars would be here beside me as well. Sometimes you hit it a little too high, sometimes it's a little bit off balance, sometimes it goes too low. It really starts to bring attention to that is life with a chronic condition. Think about having to bounce this balloon when you're trying to drink coffee and eat your breakfast every morning. Those types of things and little experiences like that really start to make an impact to understand what life with a chronic condition is like. And I strongly encourage at your next team meeting, that's a really great exercise to help bring that awareness to yourself and your team members. Have people bounce a balloon for the whole 15-minute meeting, see how they feel about that, and relate it to life with a chronic condition. I did put some details in respects to diabetes here. This presentation is tricky because I could talk about this for hours and I don't have hours. So I am going to keep my overview of diabetes relatively brief. Again, I can appreciate that it is primarily healthcare providers that are present in this presentation today. So presuming that you have a preliminary understanding of diabetes. But in a quick overview, we know that diabetes is a metabolic disorder that's characterized by the presence of hyperglycemia. Typically, with those living with type 2 diabetes or prediabetes, one of two things is happening, or sometimes both. You may have your body having defective insulin secretion, so your body is not making enough insulin to respond to your food choices and to your lifestyle choices. Or your body is making enough insulin, but it is not utilizing that insulin effectively. So the impaired insulin action, or what we often call insulin resistance, is present. So the body is not utilizing that as effectively. And again, sometimes there's a degree to both of those things present. There is no one thing that causes diabetes, and we will explore a little bit more about factors that influence diabetes, but that's a really powerful thing to share with patients. It is not because they ate too much cake at a birthday party. I have had patients ask me that. Is that why this happened to me? Is because I overdid it? It's important to explain that diabetes does not occur in one moment. It is multifactorial, a combination of lifestyle factors, genetic risk, age, all of those need to be considered and explained to patients so that that blame and shame of living with diabetes is not as strong as it might be when they think it's because of what I chose to eat. It's also important to acknowledge that diabetes is a progressive disease, meaning that treatment requires can change over time. It can be very frustrating as a patient when you're doing all of the right things and things still change. So it's important that we explain that with patients and that they're understanding that interventions might need to change as time goes on. And that's where that team-based care and ongoing regular follow-up can really be empowering to help with those steps. There are different classifications of diabetes. This is directly from the Canadian Practice Guidelines and Diabetes Canada. There are two different types primarily. We can get down the rabbit hole of additional types such as LADA, LADA, Latin autoimmune diabetes in adults. For our purposes, we're going to keep things simple. We're primarily speaking to type 2 diabetes, and then there is type 1 diabetes. Type 1 diabetes should be considered something different. However, we classify it as the same because it is still the same metabolic disorder and similar response. However, in those living with type 1 diabetes, no insulin is made. Those living with type 1 diabetes do require injecting insulin multiple times a day. And it is an autoimmune disorder. So typically what happens is some sort of trigger illness or injury, something has triggered in the body that the beta cells are then destroyed by our own body. So it is an autoimmune process. As a result, our body is destroying the cells that we require to utilize and produce insulin. So as a result, we have to inject our insulin with type 1 diabetes. Type 2, we are primarily seeing as spoken to either insulin deficiency or insulin resistance. And it comes in a variety of ways, shapes, and forms that may present, and it comes in different degrees for different individuals. And there are different medications, different therapies that we put in place depending on what the blood sugars are responding to us. We do also speak to gestational diabetes, which is a type of diabetes that occurs only during pregnancy. To speak briefly on the different types of diabetes, again, from the Canadian Practice Guidelines, we have what we call pre-diabetes, or often you'll have patients or people say, I'm borderline. I'm borderline living with diabetes. That is typically when their A1C, our screening test for diabetes, is elevated, but not elevated as significantly as what's considered type 2 diabetes. This is their early warning sign that they're at risk for it progressing to type 2 diabetes. We call it kind of the yellow flag, the early warning sign to let you know, hey, we might need to be checking in on things. And the goal of care is to have our blood sugars resume to normal. Gestational diabetes, the reason I thought this was relevant to share today is gestational diabetes it is very common. It's unfortunately not spoken about as often, but we are seeing it more commonly than we think. And typically gestational diabetes occurs only during pregnancy. And there are significant risks to both mom and baby if the blood sugars are not managed. Given that pregnancy, although it feels long, it is not that long of a period of time. The interventions are quite intense. And one of the big things that's important to know about gestational diabetes is that the blood sugar targets are different. I find this is relevant because when we experience gestational diabetes, it increases your risk for development of type 2 diabetes later in life as mom. So I often have patients who are now in their 50s or 60s and they're newly diagnosed with type 2 diabetes, and we are exploring, do you have any previous knowledge? Well, I had gestational diabetes with my kid. The expectations during gestational diabetes, the monitoring parameters, the blood sugar targets, and the interventions are very intense, rightfully so. They are not the same as those living with type 2 diabetes. There are concepts that translate, but specifically the targets are very different, and the monitoring parameters quite often look different, which is important for patients to know, because if they've experienced gestational diabetes and the overwhelming experience of that, normalizing that in type 2 diabetes, it's a little bit, the targets are a little bit looser. They're still very important, but they're not as tight, and there is a little bit more time to be able to manage these things for a majority of patients, are important differences that we're exploring with our patients. Getting into the meat and potatoes, the kind of core things we want to explore is what do we do about it? What are some things that you can share with family members, friends, patients that you come across that are living with diabetes, and they're like, hey, I was newly diagnosed with diabetes. Anything you would suggest? These are some things that hopefully we can discuss. So it's important to understand what factors impact blood glucose levels, blood glucose and blood sugars being synonymous. Blood sugars are not just driven by food choices. While that plays a big factor, and I do have a section on nutrition, as I am a dietitian, we are going to speak a little bit more about it. But educating our patients on all of the different factors that can impact blood sugars is critical, because if they are eating all of the things they feel they need to, you have that patient that's like, I cut out all the sugars, I'm doing all of the right things, and my blood sugars are still all over the place. They need to be aware of the different factors that are impacting our blood sugars. This can also resonate with you personally or with family members. Diabetes is very common. We are all going to come across it in all walks of life. It's important that we have this appreciation. Other factors that can impact blood glucose levels in a quick snapshot version would be your physical activity levels, your medications, your sleep habits or lack thereof quite often, stress levels, and also illness and injury. One of the key things I often tell my patients, not so much at this time of year in Northern Ontario, but come spring, summer weather, illness or injury of any kind tends to raise our blood sugar. Very common example I see is sunburns. A sunburn is an injury to the skin that the body has to cope with and it can often raise your blood sugars. So my patients that get really into their gardening and they're not following sunscreen practices and they get sunburnt and they come to me and they're like, I'm not sure what's been going on the last week. Like my blood sugars have been really elevated, but I've actually been more active. I've been in the garden a little bit more. We'll talk about those types of things. So any kind of physical illness or injury tends to raise blood sugars, which is important that patients are aware of and that we're sharing those types of things with our patients. This is one of my favorite handouts. I previously, as I mentioned, I used to specialize in type 1 diabetes and pediatrics. So I have a lot of experience in that realm, although I'm no longer practicing there. This was a resource that I quite enjoy. It's from Diatribe. It's available online if you go to Diatribe and you look up 42 factors that affect blood glucose. It is available in the reference list. I will share this with my patients who just don't understand why their blood sugars are not doing exactly what they want when they're following a lot of the guidelines they heard. I'm taking my metformin, I'm balancing my meals like you told me, and I'm making sure I go for a walk every day. Why are my blood sugars still not responding as I want them to? There are 42 factors and then some that can be affecting blood glucose at any given time. This can draw us back to that blue balloon analogy. We're bouncing our balloon. At any time, these are going to play a role. There are arrows that indicate quite often the response that we see, so an increase, a stability, or a decrease. It is different for each person, but these are generally the responses we expect. So this is a really helpful resource as providers to have available. I have this up in my offices so that patients can see this and they'll look at it and they'll go, there's that many. So again, educating yourselves and educating individuals on its variety, its multifactorial can be really helpful. And I really love this resource to highlight that. You can see things like too little sleep, stress, sunburn is on there, different types of physical activity, different types of food choices, caffeine, alcohol, medications, taking not specific to diabetes medications, other medications that may be interacting with blood sugars. Those are all important things that we are aware of affecting blood glucose and blood sugars with our patients. You as a provider may not feel 100% confident in explaining exactly how, but being aware that there may be impacting the blood sugars is an important thing to be sharing with patients. Diabetes management, as a result of these 42 plus factors, we would like to think that diabetes management is linear. We'd like to think if we do the right things, follow the guidelines, we're going to see the blood sugars exactly where you want them. Quite often it ends up looking more like this, kind of getting on and off track. Lifestyle changes are difficult. They do not happen overnight. They take small, gradual steps to make this happen. So at times we can see patients struggling. We can see patients working through those and see something more like this. For some patients, it looks more like this, or maybe it doesn't look like this, but it certainly feels like this. So it's important, again, that we are acknowledging there are a lot of factors that we need to help as healthcare providers to help remove all of the squiggly line messes and move them more to the ones that are a little bit more linear, a little bit more clear, and feeling a little bit more empowered as patients. I included a brief note on medications. However, I acknowledge that we do have another webinar coming up that's going to speak specifically to the different pharmacological options for type 2 diabetes. So I am not the pharmacist. I will leave that to our pharmacist doing the future webinar. However, this is a resource that I particularly like to use with patients when they're asking me, I'm on metformin and my doctor gave me another medication for diabetes. Why am I on another one? Or I'm already on a couple medications and my blood sugars aren't working. Why am I on so many medications? Understanding the different classes of medications for patients that are non-medical is very overwhelming, but I find this visual very helpful and a great resource that you can share with patients. It highlights all of the different components of the body that are involved in diabetes management to some degree, and all of the different classes of medication and which part of the body they actually target. So for example, you can see the MET piece here is metformin. It's primarily working on our liver. If we introduce an SGLT2, we know that it's primarily working on the kidney. So sometimes when I have that patient that's like, well, why'd they give me another one? Or why am I on multiple? It's really helpful to show them. These are all contributing to diabetes, and all of our medications are working on different parts of the body to help your body manage our blood sugars. That is all to say on it. Again, I encourage attend the future webinar for further details as far as medications go. Speaking to physical activity is a key component to lifestyle management of diabetes. I strongly encourage with my patients participating in enjoyable movement. Pick something we like. We are much more likely to continue to do it if we actually enjoy it, and starting slow and building gradually with your duration, your intensity. It is very common in clinical practice to have that patient that sits down and I inquire, what does physical activity look like for you? And they're like, oh, you can see the motivation drain right out of them, like, oh, as if you asked me that. Quite often, patients are moving more than they give themselves credit for, a lot of activities of daily living, but there is a lack of intentional movement. And that's often where the conversation comes. So if you have that patient that says, oh, I'm not really doing anything, I'm very active day to day, up and down the stairs, doing laundry, those things, those are all valid. Those are all activities of daily living, but intentional time set aside for physical activity really can make a significant difference in our blood sugars. Typically, 20 minutes a day of regular movement intentionally can start to make both physical and mental health improvements. There is a strong evidence for resistance-based movements as well. So body weight movements, introducing light weights or exercise bands. There's a lot of evidence going into the strength in that, and specifically with blood sugar management and diabetes. Resistance-based movements help to improve our sensitivity to our insulin. So our body, if we talked about at the beginning, we might be seeing some insulin resistance. Introducing some of these body weight movements helps to reduce the insulin resistance. So it helps the body use the insulin more effectively. That comes from sustained regular movement. In the moment, physical activity can typically lower blood sugars, but participating regularly starts to help that overall blood sugar trend move to target a little bit more effectively. We also know that resistance-based movement has strong evidence for cardiovascular risk reduction. We also know it's helpful for bone strength and muscle density as we age. The Canadian Society for Exercise Physiology, they've actually revised some really great resources in recent years, and I do have one on the next slide. We previously I used to talk a lot about the Canadian guidelines for physical activity, which are still valid, but the CSEP has integrated these Canadian 24-hour movement guidelines and tools. These are available online. There are ones that are integrated for patients, and there are ones that are specifically for healthcare providers. I've provided an example of each on this slide. I can appreciate they're wordy, so again, I will direct you to the CSEP website to obtain these. On the left, it's an example of what a healthy 24 hours could look like for an adult age 18 to 65. I thought this was a fantastic adaptation to physical activity, and that it's talking about holistic wellness. It's not just about exercise. It talks about, yes, moderate to vigorous aerobics and light physical activity, including standing. That was previously not something we really considered. It also talks about the importance of sleep and simply limiting the sedentary behavior. So getting up and moving and those types of things. Maybe it's not exercise, but it's getting up and moving. And I really love the bottom where it says progressing towards any of these targets will result in some health benefits. A lot of patients are very all or nothing. A lot of people are all or nothing. Some movement is beneficial, and it's important to empower our patients. The more we do it, the more likely they're going to keep up with doing more. On the other side of the screen, I do have the CSEP Path for Movement Counseling tool. Really great stepwise approach to how to have this conversation with your patients in an effective way. It's very easy for us to say, we should be going for walks every day. Having the opportunity to, how do we have a more meaningful conversation to implement this with your patients really can help. And I think that these guidelines, there's one for seniors as well. There's one for children as well. And I, again, will direct you to the websites to take a look at these. But I thought that the movement counseling tools would be very helpful to share with team members to help give you some stepwise guidance on how to have this conversation for any type of chronic disease management. And we know that it can really apply to diabetes as well. Other lifestyle considerations before I dive into some of the nutrition interventions that are, again, part of the 42 factors that impact lifestyle, impact diabetes management. We do know that smoking has a significant impact on cardiovascular risk and metabolic health. So working with patients with smoking reduction and smoking cessation, if you are privileged enough to work in a team where you have somebody who's really supportive in that, perhaps your program's engaged in the STOP program, connecting patients with resources such as that can be very beneficial. Sleep hygiene. So lots more research and conversations about this happening, getting away from our screens before bed, improving our sleep habits, all of those things, improving quality of sleep, length of sleep, all of those are important to consider and help patients with. Exploring how is your sleep? When they're up every 2 hours, we do know that glucose response is difficult because the body is not sure, am I resting or do I need that energy for getting my day started? So interrupted sleep plays a significant role in diabetes management. We also know mental health plays a significant role, and there is a screen here from Diabetes Canada that talks about diabetes, mental health, stigma, and discrimination, which I think is also something that we as healthcare providers have a lot of power to encourage patients and empower patients as opposed to shaming our patients. And we need to be the leaders in minimizing stigma and discrimination. 33% of people feel anxious thinking about their diabetes, and 33% hesitate to tell other people that they're living with diabetes. I think that's quite significant, and we want to have patients that open that door to have open conversations. The more they can learn and the more they can talk to others about it, as well as providers, the more that they can be empowered to make different changes. We also know that stress management is key. So if you're having patients that are very overwhelmed with chronic stressors and life stressors, quite often that impacts blood sugars directly. Chronic stress raises our blood sugars, but we also know that it impacts other aspects of life. Stress will impact our sleep habits, our food choices, all of those other factors, and we get again stuck in a little bit of a vicious cycle of all of these things compounding to blood sugar management difficulties. In the last little bit of our conversation, I am going to focus more on nutrition. I am a dietitian by trade, so of course this is where my heavy passion lies, but in my privileged opportunities with diabetes, I'm passionate as a condition as a whole. We practice nutrition therapy in diabetes, and the goal is to empower patients to be aware of the impact of food choices on their glycemic control and support people to make decisions regarding diabetes. We are typically educating patients and informing patients about nutrition and food from a diabetes lens or perspective. I often tell people we as dietitians wear different hats, especially if you work in a setting where you see all conditions. We're not specifically seeing just diabetes, we're seeing a little bit of everything. Sometimes you've got to take off the diabetes hat and put on the food allergy hat. So I quite often encourage when we're thinking about diabetes, we're wearing our diabetes hat, we're looking at nutrition from a diabetes perspective, and that's how we are educating our patients. Nutrition therapy is very personalized, and dietitians are very passionate about education and personalization of nutrition. There is no one diet for diabetes. If it was, they probably wouldn't need dietitians. If there was a simple handout that said this is how you can eat and it'll work, great. That doesn't work for a variety of different reasons, and that's why we have specialized care team providers in this area. We are often working to match insulin to food choices. So if you're working with patients who are living with diabetes that require insulin therapy, we're not trying to limit food choices to not have to take insulin. We are trying to take the right amount of insulin for our food choices. And I can explain that a little bit more in future slides. But I strongly encourage that teaching patients about nutrition and nutrition education is very empowering. Food is quite often one thing that patients feel control over, not always, but generally speaking, patients are in a situation where they have control over food choices majority of the time. Empowering patients to know when they're looking at their pantry, what might be a better decision for me in this moment is what we're after. The goal of medical nutrition therapy always, so when a dietitian's seeing a patient or if you're speaking a patient and you're talking about nutrition in general, we always want to focus on nutritional adequacy. We want to make sure, are they at risk for malnourishment? Are we minimizing those? Are we making sure that they are getting enough of what they need? We want to teach them about meal balance and understanding macronutrients, the importance of all of those things. And we want to encourage them to have knowledge on their food decisions, the impact on their body, and specific to diabetes, how does it impact blood sugars? We also want to be applying management of comorbidities. You don't always see diabetes in isolation. Quite often it's diabetes and high blood pressure, or diabetes and high cholesterol. Those types of things need to be considered when we're introducing medical nutrition therapy for our patients. And again, that personalization to support success with patients. It is very easy to say you should eat A, B, and C, but if a patient comes to you and they're like, well, I don't like any of those things, that's a difficult situation. And that's where, again, we want to be personalizing and having those conversations. When we're working with children and families, we typically want to focus on a family-centered approach to food. So if you're working with a pediatric patient managing any chronic condition, but specific to diabetes, those patients are not always in full control of their food choices. So quite often we're working on, as a family, how we can integrate food choices to support them. I always enjoy bringing up the history of nutrition therapy for diabetes and the history of diabetes in general. Insulin was discovered in 1921 in Toronto, but insulin was discovered just over 100 years ago. In the world of medicine, that is not very old. We have made leaps and bounds in diabetes management, and I think that's why it's such an exciting time to be a part of diabetes management care, because there's so much changing all of the time. For those of you who have been living with diabetes for a long time or practicing in this area, you may have seen the glucometers that come in the size of iPads. Originally, with glucometers to check our blood sugars, that's how big they were. The very first insulin pumps were the size of laptops, like our big chunky ones that they used to wear as like a backpack almost. They are now the size of cell phones. Some of them, just minor. If we think of those sensors now that we're wearing on our arms to monitor blood sugars, all of those things are huge for the diabetes community. And I think it's really important to appreciate that insulin was only discovered 100 years ago, and we are now seeing progressions of once a week insulins available, coming to market and things like that. So lots to learn, very overwhelming. And as providers, staying up to date on those types of things, it's easier said than done, but familiarizing yourself with what's new, what's changing. 15 years ago, we would always put patients on NPH. We don't generally practice that. There is a time and a place for that, but now we're seeing a lot more basal bolus therapies if we're introducing insulin, those types of things. So it's really an exciting time to be part of diabetes. And we have learned so much in the last 30 years, 40 years about diabetes, about blood sugar response, and about nutrition and how it can play a role. It's very exciting. Many years ago, we used to be very restrictive. Prior to the discovery of insulin, it was actually basically a starvation diet, was what it was referred to as. We then have obviously grown from that, and we are very restrictive, macronutrient focused, very regimented, and you can only eat these things. We used to have practice with an exchange system and very formalized meal plans to try to help with these things with patients. There were some pros to that. It was very uniform across the board. It could be unified. We could teach that in a very concrete way. However, cons to that was it was very rigid, usually very time consuming to teach in an exchange system and have patients become proficient in it as providers. And it really doesn't reflect the food diversity that we know exists. It doesn't really personalize peace. So there is an example on the screen of a diabetic daily meal plan for 2,000 calories. It's got the carb choices and the kind of an exchange system type example. We don't do this anymore for many reasons, but this is not the way we teach nutrition education anymore. It's where we started, but we are much more flexible. We are much more focused on the patient and much more in tuned with food choices that are culturally appropriate, that fit for real life, that are mindful of food security and cost of living. All of those things need to be considered when we're teaching patients. I don't ever tell a patient, this is what you're going to eat for breakfast. I'll give them a bunch of options of these are some great breakfast options that represent some of the key things we want, such as high fiber carbohydrates, heart healthy protein choice paired with that. Those types of topics and conversations are what we're teaching and we're reinforcing with our patients. For nutrition therapy specific to prediabetes and type 2 diabetes, we're talking about healthy eating principles to prevent and manage comorbidities associated with metabolic syndrome, obesity, diabetes, those types of things. We're talking about prevent registered dietitian. There's a lot of evidence to suggest that that is beneficial for patients. It's right in the Canadian practice guidelines if you have that resource to use them. These are a list of things we may be talking about in an appointment and we would be assessing in any given appointment. So portions, meal balance, meal pattern, food and beverage choices, alcohol and substance use, label reading, food skills, cultural food preferences, how to eat away from home when we're managing these things. These are all topics that we want to empower and teach our patients about. For nutrition therapy for those living with type 1 diabetes, we're going to include all of those things on the previous screen, but we're also going to usually introduce carb counting. It's typically best practice as it's appropriate for patients. Of course, there are always the exceptions, but we are typically looking at skills and food records, and it's a little bit more intense with type 1 diabetes, especially at the beginning. Yes, you can use carb counting as a practice tool in those living with type 2 diabetes. It depends on the patient, but it is much less common practice in type 2 diabetes unless you feel it's pertinent, or again, if they're on an insulin therapy regime. If such is the case, and again, particularly in type 1, they would be on insulin. So we're often, again, trying to match your insulin to your food choices, which is where carb counting becomes an important skill. Developing positive relationships with nutrition is a key component to making sure that you are empowering patients, you're empowering your coworkers, you're empowering your parents that are now living with chronic disease and specific to diabetes. This is a list of this little diagram here I really like. If you're making a food choice at any given time, any time of the day, all of these surrounding bubbles are things that might be going through your mind. You might be looking at cultural choices, availability, cost, taste. How does it taste? When we think about diabetes, we have all of those and then all of these. So specifically with type 1 diabetes, we also think about, do I have treatment for lows? How much insulin do I have to take? What time do I have to take my insulin? What are my blood sugars before I eat? When did I last eat? There are an additional amount of questions that run through individuals' mind living with diabetes to make food choices that we at times may take for granted. So again, this comes back to that appreciation of living with chronic conditions and how can we help make these easier. As a result, what can we do as providers in your care settings, but also if somebody brings it up with you at the dinner table? Education is power. Educating yourselves, staying up to date. Diabetes Canada does their best to update Canadian practice guidelines regularly. They kind of do snapshot versions so that you don't have to get too far into the rabbit hole. They've been developing a lot of really great practitioner tools that can make it easier for you. Act with compassion and use your patient-centered care. I know that's a big thing that we're always talking about, but really taking that time to give that space for the patient to express their concerns, to provide that opportunity for you to identify what are your barriers, how can we better help. One of the big ones I strongly hope people take away from today is using inclusive language. There is a chart on the screen here that gives you some great example. Nothing bothers me more than hearing people referred to as diabetics. That is very condition first. We are patient first. And so we refer to people as living with diabetes. An individual may correct you and they may be comfortable with that, and that is fine. But I strongly encourage to share that you are supporting a patient with diabetes, not a diabetic patient. That, again, is that patient first conversation. Try not to refer to the blood sugar monitoring as testing. That makes it feel like it's pass fail. Using it as it's just a monitoring tool. We're seeing where your blood sugars are at to determine are your therapies appropriate. Using, the words, oh, they're non-compliant. They're not non-compliant. They're challenged with some of the interventions that we're putting in place and why. What are those reasons? And it's on us to kind of dive into those types of things with some of these conversations that we're having today. There are a bunch of other great examples that we can go into, but simple terms like that can really open the door to feeling more inclusive in our practices. I always like to share Diabetes Awareness Month is in November, and there is World Diabetes Day on November 14th. I encourage participate in World Diabetes Day, wear blue on November 14th, but worlddiabetesday.org actually has a whole initiative. They share really great stories. Again, that normalizing that 33% of patients that don't want to share they have diabetes, sharing and connecting them with those communities. Diabetes Month and World Diabetes Day is a really great time to bring that to your practices, to bring that for your patients. I've already alluded to several resources throughout the presentation today that I would encourage familiarizing yourself with. There's always lots, and knowing where to go can be a challenge. So I do have several in the reference, and I'm happy to share with you some of the go-to resources that we have available to us. The last thing I really like to share, again, it didn't put it on here, but one of the big things I encourage, it goes back again to that inclusive language, is please don't ever question someone with diabetes about their food choices unsolicited. So when somebody is living with diabetes decides they want to have a cupcake and we ask, are you supposed to eat that? That brings a world of emotion to that patient. It makes them feel shamed. It makes them have to explain themselves. And it makes it very difficult. As we explored, there's already 100 different things going through their mind about their food choices. That may not be the most appropriate thing. It could be, I see you're eating a cupcake. I'm just curious, how does that impact your blood sugars? They might still take that in the wrong way, but if you feel the need to inquire about it, ask with question, not with judgment. And again, generally, these people are educated and they're in charge of themselves. We're encouraging them. As I said, there's no diabetes diet. There's actually no foods off limit. Yes, there are foods that are maybe not appropriate choices and maybe we shouldn't be making them that often, and that's where we as providers in our healthcare setting can be supporting and helping them to understand those things. But try to avoid in your day-to-day, if somebody you know is living with diabetes is having a treat food, they've already thought about it. And yes, it's fair to show concern and it's fair to have open conversations about it, but again, ask with curiosity, not with judgment. To wrap up before I open the floor to questions, I want to remind everybody that chronic conditions and diabetes as well, diabetes is a lifelong balancing act. Yes, there are interventions we can put in place and we can see blood sugars changing as a result, but there are so many factors that go into managing diabetes as we've already explored. All of these things need to be considered by our patients, and that can result in a lot of exhaustion and a lot of difficulties. So again, that compassionate care and patient-centered care, supporting patients that they're living a lifelong balancing act, thinking about all of these things and our role and how we're going to help them with that is where we fit in best. I have all of the reference available here in brief. And I would like to thank NOSM and thank Bethany and the team for inviting me to speak today. Again, there's 100 different things I could have talked about related to diabetes, but I hope today opened the floor to some great conversations and helped provide some tangible opportunities and experiences or little tidbits that you can take back to your practice. I'll open the floor to any questions or concerns at this time, and thank you all for your attention.
Great. Thanks so much, Caitlin. We did actually have a question in the chat while you were presenting. One of the attendees on the webinar today, they're wondering where they can find the graphic related to different agents that address different pathophysiological disturbances. I believe it was on slide number 13 for yourself.
Yes, actually, that was a resource that was developed off of the guidelines from Diabetes Canada, but that visual specifically, it was actually in a drug information pamphlet handout. I am more than happy to share that. I think best steps would be Bethany, I can email it to you and you are welcome to distribute it to any participants that may be interested in that.
That'd be great. Thanks so much, Caitlin. We also had another question in the chat there. It says, what monitoring do you suggest for a person with a new A1C of 6 pre-diabetes? I believe there are various ways to monitor: Dexcom G7, watches, LifeLabs diabetes, health kit, etc.
Wonderful. Absolutely. So if it's a new diagnosis of pre-diabetes, quite often what happens is the doctor has told you that and they said, we're going to do your blood work again in 3 months and we'll check and see how we're doing. Ideally, you get to connect with a diabetes educator or a dietitian or somebody to help you along there, but they often will not prescribe doing blood sugar monitoring checks. The best thing I can suggest is ask for a glucometer so that you can poke your finger and see. If you're living with pre-diabetes or it's a new diagnosis, it's just anecdotal to understand how blood sugars are responding. You do not need something like a Libre or the Dexcom or any of those sensors. Quite often, to be honest, they're not covered when we're listening, when we're speaking about pre-diabetes. Coverage and those types of factors can sometimes be barriers, but glucometers typically are, and you can check your blood sugars. There are different targets, so you would want to be familiarizing yourself with what the targets are. For a majority of adults, for anybody curious, Fasting blood sugar, first thing in the morning before you've had anything to eat or drink. Typically, we're suggesting the blood sugar between 4 and 7. Any other time in the day before you eat, or we wait 2 hours after a meal, ideally that number is between 5 and 10. So if you were to be poking your finger, those are the numbers you would want to see throughout the day. So that can help give you guidance to understand what's going on with the blood sugars, as opposed to just, seeing what happens in 3 months and hoping that the changes that you've put in place are working. Another great resource I would refer you to is, if you can go to Google, but it's on Diabetes Canada. How often should I check my blood sugars? There's actually a tool where you go in and you put in your age, what your A1C was, if you're on any medications, and it'll actually tell you how often you should be checking your blood sugars, and it'll give you templates on that as well. So I think that's a really great tool. There's one for healthcare providers, but there is one for patients. So Diabetes Canada blood glucose monitoring, that will pop up to personalize it a little bit more. It can tell you if you are checking your blood sugars in any capacity, how often you should do that.
That's great. Thank you so much. Francis, you've got your hand up if you'd like to unmute yourself.
Yes, I'm a registered kinesiologist. Thank you for spending so much time talking about physical activity. I started exercising people with diabetes in 1982. And since that time, the research has only grown and grown. And it's worth all of your professional practices to make some connection with some kinesiologists. I myself have gotten a number of people well in their 80s off of metformin, off of other medications, or dramatically decreased. And yes, you touched nicely on the exercise component, and critical. And I may have been listening to something else. The critical factor is consistency. My 88-year-old mother sat on an exercise bicycle and watched her favorite game show. And for the next 12 years, she never had an elevated A1C or anything. So make the connection, and it's all about consistency. And yes, your comment about the resistance training, very, very important, particularly with the older population, not only for all the related conditions, osteoporosis, so forth, but the falling part, etc. And the results will be quicker from that. And you're more likely to get buy-in from most of these folks if you can provide them with a little bit of guidance that they, sit in a chair and use rubber bands or whatever the case may be. So very experienced at this, don't have any of your knowledge about the meds and the food, but anytime I'd be more than happy to collaborate with you guys via connection, pro bono, and I have to go. So thanks very much enjoyed the cut to the chase, talk to professionals language that you used as well.
Excellent. Thank you, Francis.
We had another question in the chat. It was, how can people without a primary care provider find a registered dietitian, perhaps to pay out of pocket?
Absolutely. Great question. Depends where you are. I know that we have people coming from, I see some of my friends from far north online here. So it very much depends on the communities that you're working in. I can speak specifically to Sudbury. There is the diabetes education program, diabetes education team at Health Sciences North. They operate out of the old Memorial Hospital. It is an outpatient setting, and you can self-refer. So you can refer if you have a diagnosis. So if it was from a walk-in clinic, you can self-refer, and they can support, and they have dietitians on their team specialized in diabetes. If you're looking for a dietitian for not diabetes related, and you're looking for just kind of general, or maybe you have some other conditions that you find you need some support with, Dietitians of Canada does try to keep an up-to-date listserv of dietitians in the area. I cannot speak to how often it is updated. There is also Ontario, somebody can speak up if they remember, but I think it's like Ontario 411, where you can call and they can connect you. Like, it's kind of like Ontario Health. I believe it's changed the name too, but you can call and they can connect you with dietitians in the area as well, or do virtual care. There are a lot of private practice dietitians available as well in different communities. Again, I can't speak to all of the communities, but I do know there are a few in the greater Sudbury area that are more than happy to see for a variety of challenges. And I do see Jay just participated. You might also be able to find someone via the CDE website. So if the dietitian that you're looking to speak with is a certified diabetes educator, which is an additional credential, they will be listed on there as well. And as Jay mentioned, CDE is all certified diabetes educators. So that would be pharmacists, nurses, anybody that's pursued that additional credential. But yes, if you were specific to diabetes and wanted a CDE registered dietitian, they would be listed on that website as well. Or any of my dietitian friends online, feel free to pop up and say, hey, you could, you do consults or private practice or anything like that.
That's great, Caitlin. Thank you so much for answering those questions there today. I haven't seen any other questions come in the chat, but we'll just give it another minute. While I wait, though, I just wanted to thank you for your time today and for your presentation. Two of the things that stuck out to me personally is the inclusive language piece. I think that's so important when talking about chronic conditions or chronic pain, anything like that. So I think that's super important that you've mentioned that. And I really had no idea how many factors impacted that can impact blood glucose and blood sugar. The story about the patient that you were working with who had a sunburn, that was surprising to me. I didn't think that something so I say so small because I think sunburns are so common during the summertime, how impactful that can be for someone who has a chronic condition. So that was huge. I'm really glad that you touched on that piece as well. So thank you so much for that.
Thanks, Bethany.
Absolutely. Kara, I see you've got your hand up if you'd like to unmute yourself.
Yeah, I just wanted to thank you, Caitlin, and congratulate you. I thought that was a really well done presentation, very comprehensive. I was never a CDE and you taught me things, so I'm sure there's others online who are healthcare professionals, as well as there's a couple learners online. So we've all learned something today. And like Bethany, a couple things that stood out was, yeah, definitely your inclusive, your practical patient first language. I think giving concrete examples is always helpful for practitioners. Sometimes we don't quite know the words and you gave them. So thank you for that. And then of course, your comment about how individualized nutrition therapy is. I think your quote was something like, if one size fit all for diets, you wouldn't need dietitians. I think that's, I might quote you.
I have used that multiple times.
Yeah, it was very cute. So anyway, thank you again.
Thank you very much, Kara. And I appreciate the feedback. If anybody has future questions or wishes to connect further on anything I've touched base on, I think it comes across. I'm very passionate about what I do and happy to connect with people about any diabetes related or any nutrition related things. I'm more than happy to have my brain picked, share resources, any of those things. And I really appreciate the feedback because this was just hey, anybody interested in talking about diabetes? And I said, yeah, I am. So I'm glad that this gave some tangible resources and kind of hit the mark of what people were interested in. And, maybe down the road, I can redo it in a different capacity. So thank you all for attending during your valuable lunch hour with me today.